Howie, it's great to see you, and welcome to Health and Veritas.
You're Harlan Krumholtz.
And you're Howie Foreman, and we're sitting together today.
Exactly. We're in the studio. We're physicians and professors at Yale University. We're trying to get closer to the truth about health and healthcare. This is one of our periodic episodes without a guest, and there is so much news to go over right now that it gives us an opportunity to catch up on a lot of things, some of them longer, some of them shorter. And I want to start off, Harlan, by wishing you a happy autumn.
Well, thank you, Howie.
Yeah. And what comes with autumn?
What comes with autumn?
Flu season.
Oh, okay.
Flu season comes with autumn. And so we're about to enter what we usually used to call cold and flu season. Now it's cold, flu, and COVID season, I guess. When we started the podcast, COVID was front and center. We talked about it an awful lot. We don't talk about it as much right now, but it's not because it's gone or unimportant. In fact,
we're just finishing a big wave.
Yeah, no, exactly. It is still there. It's still killing people, still hospitalizing people. But fortunately, we have tools. We have tools to prevent it. We have tools to treat it if you get it. And last month, the CDC did approve new boosters for COVID, which include 2 from the mRNA manufacturers, that's Moderna and Pfizer, and 1 from Novavax, which is a protein-based vaccine. And while the 3 versions are targeting slightly different strains, most scientists believe that they are relatively protective to the degree that they need to be to keep everybody safe. And every month that goes by the way, highlights to me that our vaccination program has turned out to be safer than I once thought. And I know you've been doing some research about vaccine-related side effects, and I want to get your take on that. But every time I've gone back to look at the issues that people raise, like is it safe in pregnancy? Is it causing an unusual number of cardiac deaths? All those things, the vaccination programs have turned out to be safer than I think we originally expected. And it's not to say that we don't have adverse events or idiosyncratic reactions, but study after study shows overwhelming benefit, and certainly more benefit than risk in all age groups, but especially older people and those who are immunocompromised. And for the record, I don't know if I ever told you this last year. I probably did, but I went for Novavax last year, and I'm going to go for it again. And for me, the side effect profile seems better. The evidence is that maybe it's not as effective, but the side effects are better. And so that's what I'm going to go for again. But when I talk to people, and I'm curious to hear what you think, I tell people get vaccinated for almost everybody. Maybe younger adults have a bigger decision to make. But if you're elderly or immunocompromised, you should be thinking about even getting a vaccination every 4 months or so as well, particularly during these peak periods. But so that brings me to the Surgeon General of the state of Florida, which we talked about once before. And I hate to say this about anybody, and I'm not making an ad hominem attack, but he seems to be off the rails. I mean, it's the only way to describe it.
What does he say?
He has said that they lack efficacy. He said that they've been targeting the wrong viruses. He says that they're unsafe. He talks about contamination of them. He has continued to use this rhetoric. He issued a release a week ago. We're going to put this in the show notes. And our friends at Kaiser Family Foundation Health News came point by point, talking to many of our own colleagues, people that you and I know, going point by point of the things he raised and just talking about how ludicrous it is. These are not edge cases. This is not like, should you be vaccinating your 20-year-old son? These are, do they work at all, and should elderly people be getting vaccinated? And again, we know that every drug has side effects. We know that everything we do, whether it's food, devices, drugs, there's unintended consequences, things might happen, but the evidence is so strong in favor, and hearing what he's saying makes me think that this is all about just getting attention. So I'll just say on my own, I'm reminding our listeners, go out and get vaccinated. Go look at the CDC website at the evidence, see if that helps you to make your decision, but schedule it now, both for COVID and for flu, and if you're elderly, RSV as well. I don't know. What are your thoughts?
Well, maybe I'm not quite as an enthusiast as you are. I'm not against either. I'm just thinking that the virus is in a very different phase, and meaning people are dying. About 1,000 people, I think, in the last week have died of COVID. I mean, we're in the midst of a surge, and people die. It's an important risk for people, but for people who are healthy, I don't know what is the margin of benefit for these vaccines. And I'm also little confused, so it rolls out in the fall like flu. Well, flu is seasonal.
Yeah, I know.
COVID's not seasonal.
Right.
So, I mean, what is this idea?
Or at least it has 2 seasons,
Well,
maybe.
at least it has 2 seasons, sometimes 3. I mean,
Right.
we have peaks. We don't
Right.
know what's going to happen in the future. When should you get it? I mean, some people are of the mind that you really should be getting it about 2 weeks before you think you're going to start getting a peak. Should you watch where there's going to be spread? Because
And we talked
immunity
about that
wanes.
last year. That was sort of my thinking last year. I was going to wait. At a certain point, you got to stop waiting. But it does seem the evidence that has come out about the last set of boosters, I think, was about a 50% reduction in risk to individuals.
Well, of course, there were no trials.
No, exactly. You can't do the randomized trials
And
the
the
way you
people
had.
who are getting vaccinated tend to be healthier people.
And people that may have had previous infection, and certainly people that had previous vaccination. Well, but what about you? You're in a category that could get vaccinated, should get vaccinated. What are you going to do?
Well, I'm going to get vaccinated. By the way, flu vaccine, I feel much stronger about. And I'm not even sure why I do, except that maybe as a cardiologist, there have been studies that show that flu vaccine is associated very strongly with reduction in cardiac events,
Right.
and can, people who are vulnerable, particularly for cardiac disease, heart failure and so forth, these people are vulnerable and flu can tip them over. I will say, by the way, for people like that, I'm much more enthusiastic about the vaccine.
Yeah.
I'm just saying what do I do with my son who's, 37 years old?
But that's what I'm
and
saying.
otherwise healthy?
I think those are edge cases. And I'm
Yep.
totally open to that. And that's why I said, read the evidence, make your own decision. For me, I'm approaching 60, I'm not in a category that says absolutely I should get vaccinated. I'm going to get vaccinated for the same reason I'm going to get flu vaccinated. It's about a 50% reduction in risk statistically over time. We have less evidence with COVID, obviously. With flu, we have a lot of evidence over time. Some years are better than others.
Yeah, but I do think it's a decision people will make. As you know, I'm a novid still. I haven't
Yeah.
been infected, so I'm thinking the vaccine might be even more important for me. But yeah, I mean, I just don't think we're in the moment where we say everyone absolutely has to, regardless of your preferences. And
I don't think
values.
so. And people need to understand that the CDC website, which recommends for all age groups, that's all it is recommending. It's not absolute. I think everybody should always make decisions about everything they put in their body, thinking about the risks and benefits.
And by the way, there are other vaccines that are also important. Pneumovax, I think, is very important.
Yep.
Shingles, I think, is important. Are you getting RSV?
I'm not getting RSV.
And why not?
I don't think it's even recommended for me at this point. I don't even think the CDC makes a recommendation of RSV yet for me.
Too young?
Too young. I'm
Yeah.
very young,
You're
Harlan.
very young, yeah. Well,
Thank you.
You're
Thank you.
fortunate.
Thank you very much.
All right. I got my RSV.
So what do you got?
Well, I wanted to talk a little bit about, there's been a lot of news reports about a Commonwealth Fund report that went out. This report called Mirror Mirror 2024 was just released, and it compares the U.S. healthcare system to 9 other high-income countries' healthcare system. Spoiler alert,
I know.
news isn't great for America. And, I've been on this rant about this, over the last 20 years.
Yeah.
At the margin, we've spent, I estimate, maybe $16 trillion more dollars above and beyond what we were spending. That is, we're throwing additional money into the healthcare system. By the way, inflation adjusted $16 trillion more dollars. And so despite spending more money on healthcare than any other country in the world, the U.S. ranks dead last when it comes to key measures like health equity, access to care, overall health outcomes. That means on average, Americans live shorter and sicker lives than people in countries like Australia, the UK, Netherlands. Now, I've heard people say, but that's not everybody. If you're wealthy in this country, you live well. First of all, that's part of the problem.
It is absolutely part of the problem, but it is true. It is true that, like, if you are in the upper class, if you're in the upper middle class, we probably do have the best.
But we still lag in access, out-of-pocket costs.
Yep.
And by the way, health equity should bother everyone, no matter
course.
where you are in this
Yeah.
country. And so the report highlights several major issues. First, 25 million Americans remain uninsured. And many of those who do have insurance, we talk a lot about underinsurance on this program, still struggle with all these out-of-pocket costs. As a result, a quarter of Americans can't afford to get the care they need when they need it. And this leads to delays in treatments, preventable deaths, lower life expectancy. On top of that, lower-income Americans face even more significant barriers, meaning healthcare is not only expensive, but the quality tends to be unequal. And so you add that on top of this issue of access itself. You and I are well connected. Even when we want to get appointments or we want to get things done, we have to pull strings. We have to call people. Imagine people who have no power in the system.
Yeah.
There was a conference last week that the Department of Medicine ran around health equity issues. And, time and time again, speaker after speaker are sort of pounding these issues. I'll say it's not all bad news. We rank second in what the report calls care processes. This includes things like preventive care, patient safety, coordination of services. So these are kind of the traditional quality metrics that people look at.
Can we pause for that for 1 second? Because they specifically call out the things that you've had the biggest impact on when they talk about care processes. They talk about cardiovascular and cerebrovascular interventions. That's your work. You've had an enormous impact on it. I've said it before. But can you talk a little, I know you were about to, I think, before I interrupted you, the difference between process measures and outcome measures and structural?
So the structural measures are, do you have the capacity within the system to do something? Do you have a high quality hospital? Does it meet regulatory requirements? And what's your nursing to doctor ratio and so forth? Processes are, do you do the right things?
Right.
And then outcomes is, are the right things happening as a result? That would be lower death rates or lower complication rates, lower readmission rates. In cardiovascular disease, certainly for a long time, we were elevating the quality of care, the processes that were occurring, and we were getting better outcomes. We've stalled a little bit, actually, in the last couple of years, but there was a lot of gains in there, and we rank well. I think what this report tells me is that we need to keep our foot on the gas for how well we're treating patients, how well we're providing this kind of care, but we can't be indifferent to all the other forces that are also part of the performance of our healthcare system, the health equity, the access, the satisfaction, and overall health outcomes. I mean, I've said this for a while. On our watch, while we've done better, for example, in cardiovascular disease, life expectancy is actually going down in recent years, not even counting the pandemic.
Right. But again, I'm just going to push back a little on that. And this is a question my students ask me all the time as well. Isn't that partly due to the fact that we have more obesity in the United States, or that we have more freedoms in the United States? Sometimes, the state of Connecticut doesn't have helmet laws for motorcycles. Isn't some of that
more guns?
More guns. Aren't some of that due to things that have nothing to do with healthcare, but just have to do with
look, you and I are in healthcare. We can have a very narrow view and say our job is only reactive.
Right.
So our job is only when people actually get sick or get injured.
Right.
That how well do we do helping them get back up? Or we can say, gee, healthcare is also about slowing the demand for healthcare services.
Yeah.
And we should be paying attention to health people, for example, in the city of New Haven, in the county of New Haven, and saying we are not successful if we treat every heart attack, but every year the heart attacks are going up.
Right.
We can't declare victory unless we actually get to the root cause of the problem and help people live longer, healthier lives. Your students aren't wrong. Those are part of the social determinants. Those are part of the context and environment. But, we want to, without telling people how to live their lives, create the opportunity for people to live longer and healthier lives. And that's, I think, part of our job.
Yeah, no, and look, the gun issue is a really key issue as well, because I think about half of all gun deaths are suicides. Depressed person wanting to commit suicide without a gun available is far, far, far less likely to kill themselves.
And accidents in homes and
right.
just,
so many things.
Yeah.
So it is depressing to me that we make so little progress. I think that's either their 8th or 9th release of this report, which they do every 2 or 3 years, and it doesn't change.
We're not getting
much.
better. We're not getting better. That's a big deal. All right. So what else is on your mind?
I want to give a quick. We talked about flu in the first segment. I just want to quickly remind people we had a question on TikTok. Somebody asked me, "Can I talk about the cases in Minnesota?" And quite honestly, at that moment, I didn't know about the cases in Minnesota. 2 children attending a regional fair in Minnesota were exposed to what is real swine flu, meaning this is flu that swine flu, pigs that get flu, not the swine flu of 2009 that was a human flu, but this is a flu that really only affects swine. But because these kids got a little bit too close to the pigs, they got this flu variant that's called H3N2V for the variant, meaning that it's not a typical flu that's circulating.
So do you know how this happens? I mean, a lot of people get flu. A lot of people go to fairs. A lot of people maybe we have Guilford Fair this week.
Yeah, exactly.
Pigs were around. But they don't end up getting characterized. I mean, the variant of the virus doesn't get characterized. How was it that these 2 kids end up getting characterized?
So what happens is they go through a flu test, and because the CDC wants to track the types of flu that are circulating, they will serotype these. Particularly early on, you want to know what's beginning to circulate. And they just randomly found H3N2, which is not the ones that they were expecting to see. And it was this variant, not the usual human-type variants that circulate. The kids did fine. They recovered fine.
They live on farms, or they were at...
They were at a fair.
They actually were just like I said. They were at a
Yeah, literally at that. That's what I meant. It was literally like our
a state
fairs.
fair, yeah, or
Exactly.
county fair. Yeah.
One of them, I think one of them said they were physically close and one was indirectly close. I don't know what that means if one was actually kissing the pig, but something was going on.
No, like the kids are going up and petting these animals.
No, of course. Yeah, I would.
Yeah,
I mean, like you bring me to a pig, I'm going to get close.
Okay, I don't want to hear anymore.
I know. But anyway, it was just interesting. The good news is there is no evidence that this swine flu, this particular variant, is circulating between humans. And again, for our listeners, what we worry about with H5N1, what we worry about with these swine variants is they can transmit from an animal to a human. We've proved that. As long as they're not transmitting between humans, we're in a safe situation. So these kids have recovered. They've done fine. But I just wanted to clarify that for people who might be interested. And again, the current flu shots that are out there are trivalent flu shots. They have 3 different viruses they're protecting against. That's something that our CDC and FDA make a decision in advance about, have to figure out what will be the circulating variants. COVID, same thing. That's a monovalent booster that we're dealing with. Flu, it's a trivalent booster that we're dealing with. And at the moment, at least, we hope that we have the right flu vaccine for the season.
So, I wanted to take up another topic out of, let me just say it like this, tongue-in-cheek, out of left field.
Yeah.
So, you know what the 50-50 Club is?
I do.
You do?
Yeah, I do. I used to be a big baseball fan, and there was no such thing as even contemplating the 50-50 Club, but now it's possible.
So people may have read that this Los Angeles Dodgers, Shohei Ohtani, who was with the Angels before, came over to the Dodgers this year, who is a two-way player. I mean, he can be a pitcher and a fielder, batter, of course.
A great pitcher and a great player.
And probably the greatest baseball player that has ever played the game. And this year, when he's recovering from an injury, so he's not pitching this year, but he's batting because of the designated hitter rule. And he enters the 50-50 Club, which is 50 home runs. By the way, he's already now exceeded that.
Right.
And 50 stolen bases. And the reason this is so unusual is because the people who are usually hitting the home runs aren't the speedsters who are...
No, Ricky Henderson was like, I think, 30-30 Club or something. Like, that was a huge deal 40 years ago.
And Canseco was 40-40, Jose Canseco, but he was taking steroids, so people discounted that performance. But Ohtani, here's what the thing I wanted to raise about this, Howie, because it is a magnificent achievement. And you watch him, and he seems like the natural. I mean, he seems like he just is like born to do baseball. And by the way, these home runs aren't little piddling shots over the wall. I mean, they're going to the second.
They're monsters.
Other monster hits. And it just is a moment to reflect on what does it take to do this. And I started reading about him. And, from a very early age, he set a very high goal for himself. And he put together this thing called a goal matrix. I don't know if you've seen this yet.
No.
Where he was sort of saying, like, my goal, and this was like from what time he was very early in his career, was to be in the top draft list within one of the top teams. And around this matrix, he puts what are going to be his goals for himself. And he puts building body, mental, humanity, lucky, breaking ball, pitching speeds of like 100 miles an hour, and sharp movement. And then he builds out from this matrix for each of these points about things he's going to do to build on this. By the way, and the humanity is charity, courtesy, trusted person, ability to continue, thanks, planning, a person being loved by everyone, and sense.
That's great.
What I mean by this is that these things don't happen by accident. I mean, in the same way that when you watch LeBron or Kevin Durant or some of these people, I mean, the number of hours that they put in, the dedication to the craft, the sort of will.
And the value system.
The will to be excellent. And so when you see someone like Ohtani, you think like, wow, that's amazing. He accomplished something amazing. But what you don't ever see is everything under the surface that it took to get there. And when I was reading this about him, I admired the accomplishment even more because it wasn't just like he was born with this gift. He had a gift when he was born, but he grew and cultivated it, his craft. Anyway, well-deserved performance by him, incredible.
Yeah.
And,
no, it's exciting it draws people into baseball who might not have been interested in baseball before, but the idea of a pitcher also being a fielder is just unfathomable. I mean, in history, Babe Ruth is probably the only other one that was able to successfully do both, and even he gave up the pitching very early on.
So Ohtani created this matrix first when he was 15 years old, and he basically took it upon himself to say, I'm going to approach this with meticulous detail. I'm going to keep the goals to myself, which is interesting, a certain humility about it. But be specific about time and measurement in order to get better. Anyway, I just had to admire it. I don't know what it has to do with health, except that, if we want to get better in healthcare, we also have to dedicate ourselves and
measure
be
it.
very specific about
Yep.
what it is we're trying to do.
That's right.
Yeah.
That's right.
Yeah. All right, back to you. I promise you I'll get back to healthcare.
Yeah. So let me tell you about my frustration this week with a company that many people know, Aetna CVS. So I've been on a cardiovascular drug that you know well called flecainide, which is for my paroxysmal AFib. It's extremely effective. I talk about it in class all the time because it's pennies. It used to be pennies per pill. Generic drug. I used to say it's just a miracle. It was expensive when it was called Tambicor back, when it was a brand drug. Very inexpensive.
This drug has a jaded history.
I do, because when I was an intern, it was pulled off the market for
people with left ventricular systolic dysphonia, where their heart wasn't functioning
literally
well, and they were having arrhythmias, ventricular arrhythmias.
And causing sudden death. So it's not a small thing to imagine that I've been on a drug for 11 years that might have been pulled off the market.
Was repurposed,
right.
and found to be highly efficacious and is widely used now for
Right.
an atrial arrhythmia, atrial fibrillation, in
Right.
people who have a otherwise normal heart.
Right, which is thankfully me, and it's been a great drug. So I've been getting this drug from Aetna. It was costing a few dollars every 3 months to get it. Even before my deductible, it was not that expensive. By April this year, it was $23.18 for a 3-month prescription, which is not too high. It's a lot higher than it was 10 years ago, but everything is more expensive. In June, it suddenly goes up to $39.16. Okay, it's about a 50% increase. And I'm
$39.16 a month.
Yeah, every 3 months.
Every 3 months.
But very inexpensive still, but still 50% more than it was just before. And then this month, $67.66 for the exact same thing. And so I became sort of livid over this. I started looking this up everywhere. And, and I have a high deductible health plan, so I'm very sensitive to this. I can afford this. A lot of people might not be able to. So I looked at what the prices were everywhere else. And Mark Cuban's pharmacy charges $14.96 for the entire 3 months. GoodRx shows a range of prices from $20.67 up to $61.47. Again, without insurance.
So the GoodRx means that if you go to different pharmacies, you will get different prices.
Yeah, they show you where the cheapest prices are at different pharmacies.
That's always amazed me. Basically, within one town, the price can range that much depending on which pharmacy.
That's right.
How can that even be?
Because people anchor to one place and they won't shop around. So Costco might be the cheapest for this drug and Walgreens might be the cheapest for that drug, and they count on that.
Wow.
It's terrible. So Aetna's own site showed my drug for $50, not the $67.66. So I called them up about this. I thought for sure they were going to be like, oh my God, this is just an error. And they proceeded to tell me that it was probably because I hadn't exhausted my deductible. And I quickly said, if I haven't exhausted my deductible in September, I certainly haven't exhausted it in June or April. So that can't be the explanation, in which case they said again, it's probably your deductible. Started to make me frustrated. I've elevated it, escalated it for them. I've elevated it within Yale University. I know this will get solved.
Note to listeners, don't get under Howie's skin.
Oh, my God. But the point is, Harlan, this is going on everywhere. People are being taken advantage of without knowing it. Large corporations do things without caring about what the impact is. And I'm the guy that you don't want to mess around with, but most people are not somebody
So let me
who's
ask you
going
this.
to look into it.
Would you be able to go to Cuban's pharmacy and buy it? Would that count for your deductible?
No, that's the problem. So that's the problem is if it didn't affect my use of the deductible, of course, the simplest thing would be to just start ordering from
Now,
Mark
why
Cuban.
wouldn't Aetna want to use the cheapest place it's available?
So Aetna is, as you know, 3 different organizations, right? It's an insurance company, it's a retail pharmacy, and it's a PBM.
PBM, yeah.
They're making money on all 3 angles to this. And so they have no incentive to make this work well.
Wow.
They're literally saying to Yale, this is what it costs, but they're saying to their own retail pharmacy, we've got a dumb guy over here who will pay a lot more for this than he should.
That's wild.
It's frustrating.
That's wild. So we'll have to stay tuned for the end of the story.
I'm confident that this will get resolved. For me personally, I wish I was as confident to say that this is not going to occur again for hundreds of other people at Yale and across the country. It's very frustrating. I will say to people, it does make sense to look at what you're paying for things because there will be these irrational pricing discrepancies arising.
That's amazing. Can I go off on something else?
I love it.
All right. Well, look, there was an interesting article that came out in Nature Medicine that I wanted to talk about that kind of caught my eye. So this was some research on brain aging, which has got my attention. And if you've ever wondered whether aging affects the brain differently across the globe, or why some people seem to age faster than others, given, with cognitive function, this study actually, provides some insight. Researchers in the study used something called brain clocks. These are models that measure the difference between a person's brain age and their actual chronologic age. So they'll see, what age are you on your birthday? But because they've looked at a lot of people, they're able to make some assessment of whether or not your brain is aging faster or slower. And a lot of this is based on imaging studies.
Yeah.
So ideally, these two ages should be very close. And when someone's brain age is higher than their chronologic age, that suggests accelerated brain aging, obviously something we want to avoid. So here's the kicker. The study found that brain aging is not the same everywhere. And they analyzed data from over 5,000 people in 15 countries, including Latin American countries and places like the US, Japan, China. They discovered people in Latin American countries have larger gaps between the brain age and chronologic age, meaning that they're aging faster. And their supposition is that this is really about the environment, that several key factors probably are contributing to this. Like, well, there's a lot more socioeconomic inequity and maybe higher levels of stress, but also higher levels of air pollution, poor access to healthcare. And what they're suggesting is it's creating this kind of brain stress that wears down the brain over time, and that living in areas with sort of these unhealthy environment and context of lives, can make it more difficult. Now, look, this is all predicated on were those representative samples in those places around the globe,
Right.
and what kind of inferences can you make? But this tool of being able to now be able to look at the brain, be able to make some sort of assessment, not just for people who get all the way to dementia,
Right.
but just to say, is your brain aging faster than you are? Or are there things you can do to make it age slower? And of course, we've seen a lot of other things. Another point in this program, I've talked about the alcohol, and
That's what I was going to ask you.
there
Yeah.
continues to be a drumbeat of momentum around saying there's no safe level of alcohol.
That's right.
And one of the things that's also aging the brain faster is exposure to
That's
alcohol.
what I was going to wonder about.
So they weren't able to really pull that out in this study, but I think increasingly we're going to be seeing what can you do to maximize your brain health in the same way we've been seeing this for around cardiovascular health, because nobody wants to just live longer if you don't have your wits about you. So this is about, I think we're going to see more and more of this. I'm not saying this is an authoritative, definitive study, but I was interested in it and the way that they're talking about these exposures. I'll just say one last thing. There is, in cardiology, a growing area of environmental cardiology, talking about how pollution,
Right.
stress, noise, things in our environment that we're exposed to are also accelerating cardiovascular disease and unhealthy aging of our hearts. I'm sort of seeing these parallels between heart and
I will
brain.
say, I don't know how well it correlates, but when we read head CTs, which is probably, probably reading about 20 of them every shift or 15 to 20 every shift, we always...
Do you notice this, that sometimes people say like, oh, this person looks like they're...
We frequently will say, like, this is a young-looking brain for someone who's 80, or sometimes you look at somebody and you're like, this person's 45 and their brain looks like they're 85 years old.
And what are you keying off of when you say that?
Size of the ventricles, the atrophy, the
soul
cortical
side,
atrophy.
right?
Yeah.
The sort of...
Yeah.
Yeah.
How much the brain has shrunk.
Oh, really?
Yeah. I mean, and you see it. And look, there's a huge... range of normal. So we'll see 40-year-olds that will look very old. We'll also see 80-year-olds that look young. And I don't know how well that correlates with dementia and other real outcome measures of aging, but we do see an enormous variation.
Yeah. Wow. That's amazing. All right. What else have you got?
So I wanted to ask you really quickly. I got a question from a guest last week about the AirPod hearing aid issue. And I just wanted to know from you, we talked about it a little bit. Here's what I came up with, and I'm just curious if you know differently. From what I understand, there's a software part of it, and then there's a hardware part of it. Apparently, there are some individuals that say even the existing AirPods, the ones that I have in my pocket right now, can use software to adjust hearing so that you can turn it into a hearing aid. The new thing that Apple is introducing, these AirPod Pro 2s, I think, are a different level with new software. Do you have any sense about what is making these different? Like, what is the advance that Apple has made here?
Well, I think there are two things. One is that they went through regulatory approval.
You mentioned that.
Authorization.
Right.
You know, I think that they went through and produced the evidence. But to me, the thing that was interesting was that they have the capacity to do a hearing test on you. So that they are customizing the hearing aid for you, what you need, based on how well you did on the test. I mean, I don't want to say how well you did. It's not like you pass or fail.
Right.
It's people have different deficits.
They have losses in different ranges. Yeah.
So that this thing is able to make those kind of adjustments. But I thought that was pretty cool.
It is cool. I mean, it's the idea of actually having an input from you in a test and then applying that input back to augment your hearing in one frequency range or another or multiple is really impressive to me. But it was a question that was posed, and I'm still trying to wrap my head around it. I think in the next month or so, we'll start to see the actual product out.
Well, and it wouldn't surprise me to have other people follow suit. I mean, the thing is, Apple's got deep pockets, so they could spend, it takes a fair amount of investment to be able to pull the data together and present it to FDA and so forth. But I think what we're seeing on the horizon is a lot of this kind of happen.
The future is really exciting.
It is exciting.
What do you have to wrap this up, Harlan?
All right, well, there was just one other thing. You know, we've talked a lot about these efforts to pull together large-scale primary care initiatives, you know, companies that have sort of Oak Street's one of them, you know, and
which is CVS Aetna. So it's our theme for the day.
So, you know, there were companies that formed that said we can deliver primary care more efficiently. We can be able to provide higher patient satisfaction. And, you know, if we can bring technology to bear on this, but they were struggling a little bit. By the way, they've all sort of struggled, right? That Walmart has given up on this. Walgreens is having difficulty, the Village MD, that, you know, and so forth. And Oak Street, CVS, Caremark bought them.
Yep.
And what came out this week was the Department of Justice leveled a $60 million penalty to them to settle kickback allegations. And I guess it's called allegations because they sort of end up settling
They settle it
this.
without admitting guilt.
But what happened was that Oak Street in Illinois, I mean, where they were doing this, was sort of working with agents and paying them $200 if they could bring someone to them with a warm welcome. I was trying to figure this out, Howie, because obviously when you go to an agent, you figure they're going to benefit from selling you a certain kind of insurance, for example, or bringing you to a certain kind of place. But I guess the idea here was that the patients really weren't aware that, you know, that there was this thing happening in the background, and it tripped on federal regs around kickbacks. And by the way, it probably worked out really well for them because they grew, you know, tremendously by providing this kind of incentive to people to deliver people to them. But I think that people, when they were talking with an agent, were expecting the agent to be representing their best interests and weren't aware necessarily that they were going to also benefit financially from.
This is the chronic principal agency issue in economics. It's you're going to somebody who's supposed to be an agent for you, but instead they're a principal for the firm, and you're just describing it perfectly.
Yeah. So anyway, I thought it was interesting. To me, it just told me how much they're struggling to get people in and needing to do things like this, rather than being able to say we're providing better care and having people flock to them on their own.
Yep. No, I hear
as
you.
we know, they're all having.
It's frustrating.
Well, Howie, this has been a lot of fun. I always love being
fun.
with you, and I hope the listeners have enjoyed this too. You've been listening to Health in Veritas with Harlan Krumholtz and Howie Foreman.
So how did we do? To give us your feedback or to keep the conversation going, email us at health.veritas@yale.edu or follow us on any of multiple social media.
Yeah, and we very much want to hear your feedback. Let us know how you feel about this episode or the episodes in general, or if you have questions. As you can see, Howie's already asking questions about this. When you do that, it helps people find us, and we always appreciate knowing that there are people out there listening.
We sincerely do. We look for the feedback. We love trying to answer your questions. And if you have questions about the MBA for Executives program at the Yale School of Management, reach out via email for more information or check out our website at som.yale.edu/EMBA.
Yeah, and you know, we're here in the Yale studio, so I want to give a shout out to Ryan McAvoy.
That's right.
Does such a terrific job here, and we so appreciate.
We really do.
And thanks to our researchers, Inez Giel and Sophia Stumpf, and to our producer, Miranda Schaefer. Everyone should know that Health in Veritas is produced with the Yale School of Management and the Yale School of Public Health, and we've got a great team.
We certainly do. We really appreciate it. We appreciate them. Thanks very much, Harlan. Talk to you soon.
Talk to you soon, Howie.
Thank you.